Necrotizing fasciitis. Necrotizing fasciitis is a rapid, progressive, severe infection of the fascia with secondary necrosis of the subcutaneous tissue. It is a severe disease of sudden onset that spread rapidly. Most common affected areas are the limbs and the perineum. So what are the risk factors? You can have diabetes, carcinoma, immunosuppression, alcohol, drug abuse, smoking, chronic systemic disease, and trauma. So we classify according to etiology, where you have type 1, type 2, type 3, and type 4. Type 1, you have polymicrobial. This is the most common one. You most find them in immunocompromised and post-op patient or perineal, post-op abdominal and perineal patients who have infection. Type 2, microbial, that is group B. Group A, beta hemolytic streptococci. It is common on individuals and the common site is the extremities. Type 2 is the marine vibral fecans, and which is common in the marines, and type 4 is the fungi. So the symptoms, you have early and late. Early, you have localized abscess and cellulitis with rapid progression and minimal swelling. Late, you have severe pain, high fever, chills, rigor, and tachycardia. So the clinical diagnosis is made. You have 3 stages where you have fever, erythema, edema, warm skin, warm to tender. Stage 2, you have blister and bullae formation. Stage 3, you have hyperesthesia and anesthesia, crepitus, tissue formation, and hemorrhagic bullae. On physical examination, obviously, you'll see skin bullae discoloration, which could be ischemic patches or cutaneous gangrene. As you said before, you could have swelling, edema, thermal induration, and erythema, as you've said before, and subcutaneous emphysema due to gas-producing organisms such as Clostridium perfringens. So diagnosis, this scoring system, that is the lab risk indicating for necrotizing scoring system, where you do CRP. If it's greater than 150, you give 4 points. WBCs, that is white blood cells, if it's greater than 15, give 0 point. 15 to 25, 1 point. Greater than 25, give 2 points. Hemoglobin, if it's greater than 13.5, gives 0 points. If it's 11 to 13.5, 1 point. If it's less than 11, you give 2 points. Sodium, if it's less than 135, you give 2 points. Creatinine, you give if it's greater than 145, you give 2 points. And glucose, if it's less than 10, you give 1 point. So then you score. If it's greater than 8, then you have a higher risk. If it's 6 to 8, you have moderate, and if it's less than 6, you have low risk. So diagnosis, in addition to the components that you have said, including WBCs, including hemoglobin, glucose test, sodium test, creatinine, the gold standard for this in diagnosis is surgical exploration and the finger swipe test. So in the finger swipe test, if you are really doubting the diagnosis using surgical, or you cannot do surgical exploration, then you do the finger swipe test. So in the finger swipe test, this is what you do. You take a finger, which you easily separate the tissue along the facial plane. So if you can easily separate the tissue along the facial plane, then it is positive, and that is known as the finger swipe test. And next, we have wound swab. You do a wound swab and you take for culture and sensitivity to determine the appropriate antibiotics to administer. In CT scan, you can do where you have facial thickening, edema, subcutaneous gas, for example, in gas-producing organism, that is aerobic, or abscess and abscess formation. So how do you manage? You manage this patient wholly. If your patient is in sepsis, then you follow the sepsis protocol. If your patient is diabetic, as you say, the diabetes is one of the risk factors, then you have to treat the diabetics, and then you treat your patient wholly and an individual patient. So there's, as much as we have a normal way of treating necrotizing fasciitis, treat your patient wholly. So you can give IV fluid depending on your patient, antibiotics, obviously, as you've said before, depending on the culture and sensitivity, or to give broad spectrum antibiotics for empirical treatment before the culture sensitivity results come back. You can catheterize to monitor urine output hourly. You control diabetes, as I said before, if your patient is diabetic. Then you do radio wound excision of the gangrenous skin and necrotized tissue at repeated interval. Vacuum assisted dressing is also better and has good advantages. Hyperbaric oxygen is also has very good advantages. And later on, then you can do your then if the patient recovers and you have healthy granulation